Currently associated with Singari ENT Hospital and Research Center, Vijayawada. With his vast expertise and long-standing contributions to the field, he continuously to inspire and contribute immensely to medical community. May I now invite Dr. Prabhakar sir to kindly join us stage as a panelist for today's session. Thank you. We are delighted to welcome Dr. L. Ravi, Consultant ENT Head and Neck Surgeon at Apollo Hospitals, Hyderabad. He has treated more than 1500 patients introducing visual reality therapy for vertigo management in India. We welcome you, sir.
Now I request Dr. Lakshmi Anusha, Consultant Neurologist, Aster Ramesh Hospitals, Vijayawada, to moderate the session.
A very good afternoon to one and all, respected panelists and dear delegates. Let us wake up from our post-lunch slumber with some vertigo discussion. Case number 1. So, a 33-year-old male presented to the vertigo clinic with a 1-year history of episodic vertigo, neck pain, and swaying while walking. He used to get these episodes approximately 4 to 5 times a month, and they used to last several hours in a day or sometimes even an entire day. During these episodes, he even had difficulty maintaining his balance and gait instability during the episodes. He came to us during an acute episode. He had been to multiple doctors previously and taken many medications for his giddiness and gait instability, which had not subsided. On examination, he had a normal cranial nerve examination and motor power and reflexes were normal. There was abnormality in the balance and gait in the form of difficulty with tandem walking and increased sway on Romberg test. So previously outside he was investigated with an MRI which was already done and which was normal. So we got a vertigo panel done which included a VNG, a subjective visual vertical dynamic visual acuity and the caloric testing. So our VNG revealed the presence of nystagmus with a change in direction of nystagmus. So this is the report of a VNG, how it looks. So he had a head shaking nystagmus and also a nystagmus in all of the diagnostic maneuvers. So as you can see in this video, you notice the direction of the nystagmus, it is towards the right side. As you look, the first component is to the right side in the nystagmus. And you see in some time, the direction has now changed to the opposite side. The faster component is to the opposite side. So it is a direction changing nystagmus which is suggestive of a central cause of vertigo. In this case, a vestibular migraine. So based on the International Headache Society criteria, his symptoms meet the diagnostic criteria for a vestibular migraine. So he had a recurrent episodic vertigo and he had migraine symptom which he was telling it to us as a neck pain. It was a bioccipital headache that he was seeing, and on further questioning then he said yes, he does also have some photophobia, phonophobia, and other causes of vertigo were ruled out. So this case scenario illustrates a typical presentation of vestibular migraine in a young adult with characteristic symptoms with positive ENG findings. So the treatment plan included lifestyle modifications, avoiding triggers, that is bright lights, loud noises, stress management techniques, pharmacological treatment with acute management and a preventive management to reduce the frequency and severity of episodes. Also, the vestibular rehabilitation therapy is beneficial for improving the balance and reducing the symptoms. That was case number 1. Sir, any comments from the panelists? Yes.
Yeah, that's a typical case of vestibular migraine. Yeah. Vestibular migraine is grossly underdiagnosed in the population. It's a very frequent cause. It is the most frequent cause of central vertigo. Vestibular migraine is the most frequent cause of central vertigo. This is because it is underdiagnosed because most of the times the vertigo and headache may not come together. They may have migraine in the reproductive age group, and around menopause or perimenopausal time they start getting vertigo, and afterwards they just get only vertigo, they don't have headaches. So that's the reason this is often misdiagnosed. Then how to differentiate episodic vertigo due to migraine or BPPV, which is another common cause? The duration is important. In BPPV, the duration is only seconds. In migraine, it lasts for hours or in a day. Then the frequency. In BPPV, it will occur the same in next few days, every day he will get it. Whereas in vestibular migraine, you get an attack now, you will get a next attack of 15 days or 20 days later. So the duration, the frequency attacks of vertigo will tell you to differentiate. If it is associated with headache, it is very simple. But if it is not associated with headache, that is where the crux of the problem is. So you should ask for the duration of vertigo, and if your imaging is normal, that's a typical case of. So these are the 2 points we can differentiate clinically that it's vestibular migraine.
Yes.
As a ENT surgeon, I want to add few points. Commonest headache, even though we see a lot of sinusitis and these things, but still we wake a lot of people suffering with the migraine. If we don't want to read our entire vertigo and get giddiness or dizzy, if a patient comes with a little bit, you just ask, going questioning in a various forms, whether they are having a headache or even just if they see light, if they want to get giddiness, even if they hear a lot of sounds, uneasy, or when they are, you take history for the motion sickness. If they had their family members or somebody, even if one member is suffering with the motion sickness, then if you identify if they are having a migraines, one future at least, just start flunarizine, they will get a beautiful result. There is no need to read all books for vertigo or headache books. Most common, as sir said, is the very, very common. You can just treat them, most of the patients. And second thing sir was pointing, for treatment, you can add magnesium and vitamin D, sir. They are also using very, very useful. That's what we are nowadays, after I recently went for a vertigo course with Enupoya University, sir. They said there's no need to go all these things. If you don't know anything, as a general practitioner, I'm not telling as a specialist, you just give flunarizine, most of the people will be very, very happy. And also the drug of choice for the motion sickness nowadays is the flunarizine. I don't know how many people you are using.
We are always worried about using flunarizine on a long-term basis because we see so many cases of Parkinson's after flunarizine. So my choice of drug for vestibular migraine would still be like migraine, beta blocker, or usually if it's an obese lady, topiramate is the best. These are the things I use. The other point is regarding long-term use of flunarizine, please avoid. It's a very good drug. Why it has come into popularity? Because it has migraine prophylaxis and it is a calcium blocker. So therefore it is also effective for vertigo. That's the reason it became popular. But I am a little worried because once they begin to like a drug, like how many patients of yours, they like Pantacid, they continue to take for years. Yes. And they develop secondary B12 deficiency, vitamin. So our people, if they like a drug, they continue to take, they don't take and need any prescription. So be careful. When I write flunarizine, I write 30 or 60 and that's it. You should not let them continue that drug.
I want to add one point. We need to do the audiology test as well because Meniere's disease is something which is very common and it is also appears as a episodic vertigo. And Meniere's disease and migraine, like they are the two ends of a single spectrum of disease. So that's why there is something called as Meniere's migraine spectrum disease, right? So audiological test is one of the important things which we should add in our investigation. Thank you.
Unfortunately, both are common diseases. BPPV is common, vestibular migraine is very common, and just because a person has vestibular migraine, don't say every vertigo is that. He can be having BPPV. Meniere's patients, again, they are more prone for migraine and also vestibular migraine patients, their imbalance is worse. Their balance is the worst. They are very poor in balance. That is why invariably they will have motion sickness if you ask.
One more point. Before that, we used to write left and right synergine or beta-histidine for whatever vertigo patients we get. But if really commonest cause, as everybody said, whether it is a vestibular migraine or next commonest cause is the BPPV. If it is a BPPV, 90% of the people we can treat on the table in the first incidence itself. If you refer if it's not a very great difficulty to learn that maneuvers, you can do Dix-Hallvik test and identify commonest cause is the posterior canal, and if you can treat by Eppleys, most of the patients will be all right on the table. There is no need to go for any treatment, no need of any synergine or beta histidines.
Go for the second case.
Thank you, sir. We'll go for the second case. So this is a 65-year-old woman presented with a 2-day history of brief but very intense episode of giddiness. There was an associated sensation of spinning of the surroundings. She felt like the whole room is spinning. And this giddiness was triggered by changes in her head position, like when she was lying down and turning to the right side, or getting in and out of the bed, or when she would look upward, the giddiness would worsen. She reports that this giddiness lasted for a few seconds to a minute, and it is often accompanied by nausea, but there was no hearing loss or any tinnitus symptom. The symptoms were more prominent in the morning, and they tended to decrease in intensity throughout the day. So we did, on clinical examination, we did a Dix-Hallvik maneuver, and on the right side, the patient exhibited a torsional nystagmus with the fast face being towards the dependent ear. That was the right side, and it lasted for about 10 to 15 seconds, and this was accompanied by vertigo. The nystagmus and vertigo were less intense or absent when the maneuver was repeated immediately after. And the nystagmus, the upper was more rotating towards the upper pole of the eye and towards the dependent side. Other neurological examination was completely normal. So video nystagmography, this is the during the Dix-Hallvik maneuver, this is her nystagmus that you can see. Can you see the torsional component? Can you see that rotatory component? That is a very typical for BPPV. That torsional component will be there, and it will be more towards the dependent ear. Then we have asked to fixate her vision on one point, and then you see the nystagmus has disappeared. So that indicates that it is a peripheral nystagmus. On optic fixation, the nystagmus disappears. So the management strategy was, she was diagnosed with a posterior canal BPPV, and canalith repositioning maneuver was done with Eppleys on the right side to reposition the otoconia from the posterior semicircular canal into the utricle where they will no longer cause any symptoms. She was instructed post-procedure instructions advised to avoid lying down or bending over for 24 to 48 hours post-procedure to reduce the chance of the otoconia re-entering the canal. So this is the Eppleys maneuver. So towards the dependent side, that is on the right side, we ask them to turn 45 degrees to the right side, then lie down. This 30 degrees downward, that is what that usually we miss doing. That has to be done. It should not be directly on the bed. It should be posteriorly 30 degrees backward positioning, and then to the opposite side, that is 90 degrees to the opposite side. So you have to wait for 30 to 45 seconds. And next is another 90 degrees to the opposite side of the dependent ear. That is, make the nose point downwards. So you see another 90 degrees to the left side, and you can see the nose pointing towards the down. Then you ask them to sit up. So this is the Eppleys maneuver. So follow-up appointment was scheduled for a week later to assess if the symptoms have resolved, and then if required, if the symptoms are not resolved, we can repeat the maneuver. And home exercise, for some people it is very recurrent, and some people tend to have post BPPV dizziness. We can advise home exercises. The brand diet of exercises may be recommended if the patient experiences recurrent symptoms or as an adjunct therapy.
Typical case of posterior canal BPPV. See, if a patient lies down on a bed for a certain time, if he has otoliths in the semicircular canals, they will group together with gravity. So they will settle down nicely after a few hours of night rest. So that's the reason the first time in the morning when they wake up, gravity influence changes the position of these crystals. So therefore they have vertigo. You can identify the canal also by history. If the patient is it waking up vertigo or wake up vertigo? If you have vertigo on waking up, then it is very likely it's posterior canal, which is the commonest cause, which is the commonest. 85%, 90% of them are posterior canal. More on the right side, because many people tend to sleep by habit onto the right side. So right posterior canal is the most common. Whereas in the night, if you are asleep, if you are turning your position in the bed, if you get, and it wakes you up in the middle of the night, it is probably lateral canal. That's one thing. Then lateral canal is purely horizontal. So if I had a doctor who was very good in description, and he told me, I asked him, do you have oscillopsia? He said, yes. Is there a torsional element in the oscillopsia, or is it just jerky? If it is just jerky oscillopsia, it is lateral canal. If it is torsional oscillopsia, it is posterior canal. That way you can pick up waking up vertigo, wake up vertigo. Type of oscillopsia will tell you what it is. And treatment is not beta histine, not cinnarizine. Treatment is repositioning. If I can identify the canal, I will do the procedure, do it again after 1 hour, or ask them to come again after 24 hours. I teach them the same procedure and ask them to practice 3 times a day, 3 to 5 times in the morning, 3 to 5 times in the afternoon, 3 to 5 times in the evening. The same procedure if I know the canal. If I don't know the canal, I tell them to do brand off. Or sometimes I tell them to do both sides, right and left. Usually the Simmons maneuver is simpler, unless it is a home apply. Home apply, they just use a pillow. It's very good. Very effective. That 30 degrees extension you will easily get if you place a pillow under the shoulder.
Yes, sir.
Very effective, very used, because you can't tell them to do applies at home. They can't hang their bed across the bed. So you ask them to use a pillow under the shoulder and then lie down onto one side. You get that 30-degree extension and then ask them to toss over. That also you can teach them. So treat, and most of these patients will have vertigo, and they would have seen a general practitioner or any home family doctor. He would have an X-ray cervical spine. Because of vertigo, he keeps it very stiff. So he'll have an X-ray spine. And X-ray spine will show some spondylosis. So he'll make a fantastic diagnosis of cervical spondylosis, vertigo. It never produces. Cervical spondylosis does not produce vertigo. It is a misnomer. It is not a concept at all, because it has got nothing to do with vestibular connection. The only way you can turn your head on your body is through the neck. So when you turn, and vestibular system is very sensitive for head movements. So the only way you can turn is by turning your neck. So that doesn't mean problem is in the neck. Problem is in the vestibular system. It is because you can turn your head only by moving the neck. So that is not at all an entity.
In my practice, like after doing the repositioning maneuver, like I make the patient to sit for 15 to 20 minutes, and then again I check for the Dixhall pike, and if the Dixhall pike is negative, I ask the patient to leave and come back maybe after 48 hours or 72 hours. If it is still there, Dixhall pike, then like it is positive, then like I do the maneuvering again. Yeah.
There is what is called post-positional dizziness. If you go into the history, when they have this symptom, it is real torsional oscillopsia. But after repositioning, they will be unsteady. But they don't have that torsional oscillopsia. That is because the free particles are in the utricle. So for post-positional dizziness, you have to give some time for it to settle down, and you may give an antivertiginous drug for a very short while. And I won't say that I will never give. I'll give if there is, to prevent post-positional dizziness. It is definite entity. Some people agree, some people don't agree. But on practice, we see this, and I have seen this personally. That's why I believe in what I see and what I understand.
Yeah, residual dizziness after the BPPV is very common. As sir said, like it is also called as utricular overload syndrome. So that doesn't give a typical spinning sensation, but it does give a swaying sensation, yeah, unsteadiness or dizziness. Yeah, but they don't have nystagmus in that case. Yeah.
As sir said rightly, if you feel really they are feeling very dizzy because of the overload in the utricle, then you can give for a few days. Not for the people, if you give this synergine or beta-estrogen, I came to yesterday, a few days back I think, one patient came, since how long you are using beta-estrogen? He said, I am using for the last 35 years. He is using every day one tablet. See, like that people will be misutilizing. So give only for few days if at all. If you want really, if you educate the patient, you may have a little bit dizziness, don't give any gins. They will be happy and they will, rehabilitation is the most important thing in this. If you restrict them to movement again, it will take long time.
Thank you, sir. Coming to the third case, a 45-year-old male patient came with the complaints of giddiness and mild sway while walking since last 2 days only. He had the giddiness whether he is sitting, standing, walking, he had it continuously. After coming to us, then he developed hiccups and it wouldn't subside. It was continuously, it was intractable hiccups. And he also developed some swallowing difficulty. So on examination, we saw there was a head impulse test, Hint's test was done. Head impulse test showed no corrective saccade. Spontaneous nystagmus was present. It was a horizontal with some torsional component, and there was no suppression effect on optic fixation. There was a mild skew deviation with the cover uncover test. There was a positive vertical saccade, and finger was normal, but his tandem gait was impaired. And because of the speech difficulty, we examined his palatal movements. The uvula was deviated to the right side. So on further questioning, then he agreed that he had some history of skid and fall from bike 5 days ago. He did not have any major injuries after falling down. He got up on his own, there was no LOC, he had some mild neck pain for which he was just using some analgesics. So this is the nystagmus you can see. You can see the horizontal nystagmus. Subtle torsional component, a fast component to the right. So now he is asked to fixate on one point, fixate his vision on one point. See, he is fixated, but the nystagmus hasn't stopped. So there is no effect of optic fixation. That concludes that it is a central nystagmus. So an MRI was done which showed diffusion restriction image showing a acute cerebral infarction in the left lateral medulla. You can see his angiography showing irregularities of the vessel wall in the left vertebral artery, suggesting a dissection of the left vertebral artery. So he was treated conservatively with anticoagulants, anti-edema measures, neuroprotectives. His swallowing was significantly impaired and the hiccups also were quite tough to reduce. Then on baclofen it had subsided, and whatever feeds were given through the orogastric tube. So most vertebral artery dissections involve some type of trauma or a stretch to the head or neck. Sometimes the trauma is very trivial and even forgotten by the patient. This patient, the trauma was just 5 days back, and he mentioned it to us only after further questioning. He did not think it was relevant enough to tell us. The most common site of injury to the vertebral artery are at the C1, C2, or between the C1, C2 as it enters the foramen magnum, and at the C5, C6 level where it enters into the transverse foramen. So here it enters into the transverse foramen, and here it enters into the foramen magnum. These two are the major areas where it can cause dissection.
Yeah, that's a typical case of lateral medullary syndrome. Because of history of neck pain, probably a vertebral artery is injured. I've seen patients after yoga, 2 patients of yoga, 1 patient after volleyball. Typical presentation like this. The other thing, ladies, be careful. When you go to the beauty parlor, your neck is hyperextended, they wash your hair, and first it was reported that vertebral artery dissection can happen after a beauty parlor visit. Any patient, anyway, I'm going to tell you in my talk how to differentiate. My talk is going to be on patient with acute vestibular syndrome, how do you go about to decide whether it is central or peripheral? That is going to be the talk. I'm going to talk this. I won't waste time.
Yes, this third case was actually on purpose presented in this platform because the patient is a young man, 45-year-old man, comes to you just mild neck pain, dizziness. We just write some medications and send. But that same patient can go into the ICU setup and land in a very bad position. So acute giddiness, no other comorbidities are there for him. Acute vestibular syndrome versus intracranial events, history-wise and examination-wise. I think that will be the part of discussion that sir will be doing now, and it will be very useful for us. So please.
Thank you, ma'am.
I know a lady doctor. Her husband called me when I was on the way to Hyderabad. Sir, my wife is having vertigo since morning. Yesterday evening she complained of neck pain, he said. Then I told him straight away on the phone it is vertebral artery dissection, and it was dissection. So anybody who is in the not risk group, I mean no hypertension, no diabetes, young patient, so who has, even without any, it's so trivial that they don't even know that they have trauma. It can happen. So anybody with neck pain, you should always consider vertebral artery dissection or vertebral artery pathology.
Thank you, ma'am. Thank you, sir. So, now I request Dr. Ram Taraknath to give a talk on